All right, we're going to start with GI. Do you do any like HIDAs or gastric emptying studies on your job?
Yes.
Okay, good. All right, so we'll do a little bit of anatomy here, looking at the biliary tree. It's important to know the left and right hepatic ducts come together and form the common hepatic duct. Common hepatic duct joins the cystic duct, and it's called the cystic duct because the gallbladder is actually a cyst. A cyst is anything that's fluid filled, so the gallbladder is filled with fluid, so we can call it a cyst, which means the cystic duct comes off of the gallbladder, connects with the common hepatic duct, and forms the common bile duct. From there, it passes through the sphincter of Oddi into the duodenum or the small intestines. Why do we need to know that? If the patient has a blockage in the common hepatic duct, you will not see gallbladder or small bowel. If the patient has a blockage in the cystic duct, you're not going to see gallbladder. And if the patient has a blockage in the common bile duct, you'll see the liver and the gallbladder, but you won't see bowel. So it's important to know where the blockage is and what you will see on our HIDA imaging. Okay, two types of cells in the liver, the Kupffer cells and the hepatocytes. The Kupffer cells are what we call phagocytic cells. And so what their job is to pick up anything, any particles that are in the blood that shouldn't be there. So if we inject tech sulfur colloid is particles. It's going to be taken up by the Kupffer cells. That's what allows us to do our liver spleen imaging. Hepatocytes are the second type of cells. Those convert bilirubin to bile. And so the hepatocytes are going to take up the mebrofenin and allow the mebrofenin to go into the gallbladder. There's two blood supplies into the liver. The hepatic artery is just like all the arteries in our body. The blood comes from the heart and it goes and supplies it to the liver. But the second one is the portal vein. That actually comes from the digestive system. So when we eat something that has to be processed by the liver, like we take a medication, it's going to be picked up through the portal system and be processed in the liver. All right, liver spleen imaging, we don't do a whole lot of this. We're going to use tech sulfur colloid. And the important thing to know about liver spleen imaging is 85% should go to the liver, 10% to the spleen, and 5% to the bone marrow. And if those percentages change, if the function starts shifting from the liver to the spleen, we call that colloidal shift. And that's because we're giving tech sulfur colloid and the function is shifting from one organ to another. 5 to 10 millicuries. This is where it is. You're going to see basically heterogeneous uptake. It's not going to be like smooth and pretty. It'll have, looks like this basically. And you can also do SPECT imaging. Now, CT has pretty much replaced doing this. We don't do these very often, but basically this is normal. You can find some tumors. This is cirrhosis. This is colloidal shift because this is the liver. That's supposed to get 85% of the counts, but you can see that the function has shifted over to the spleen. And then this image here, this is just where we turn the intensity all the way up so we can identify the bone marrow because the bone marrow is only getting 5% of the counts. And this again, this is the liver. So we know that the activity has shifted over to the spleen. Another way we can image the spleen is what we call tech denatured red blood cells. Excuse me. So we're going to label the red blood cells just like we would do for a GI bleed or for a MUGA. But then we're going to put them in a hot water bath. And the reason we do that is we want to basically kill the red blood cells because dead red blood cells go to the spleen. So these red blood cells are still going to be tagged with technetium. They're still going to be radioactive, but they're no longer living. And so immediately they'll just be taken up by the spleen. So why do we do this? Looking for ectopic spleen. So maybe we found a mass and we want to know if it is spleen or not. So we could do a spleen scan. An accessory spleen, sometimes people have more than one spleen. And again, identification of splenic tissue. So this is what we're looking at here. This is the spleen. This is like a little extra spleen. Right there it is. So this is spleen. All right, hemangioma is another study that we can do, not very often. This is also with labeled red blood cells. Hemangioma is a benign tumor of the liver, but it's very vascular. So sometimes it's seen on another imaging modality, like you might see it, sorry about that, might see it on CT. You might see it on MRI, or you might see it on ultrasound. So patients having a scan and they find something. The only way to tell if it's cancer is to biopsy it by putting a needle in it. And we don't want to put a needle in a hemangioma because it's very vascular and it could cause the patient to hemorrhage. So before they biopsy it, they're going to go ahead and do a hemangioma scan. This is what it looks like on the CT scan, and there it is on the hemangioma scan. So again, it's very vascular, so it's going to have a lot of blood flow to it. So that's why we use labeled red blood cells. Again, there's the tumor, and there's the hemangioma scan. 15 to 25 millicuries of TEC labeled red blood cells. You're going to inject, acquire images. You could do dynamic images, you can do static images, and you could also do SPECT images. Okay, and in this one here, what are we looking at? Here is an ultrasound. Here it is in CT. Here it is in MRI, but it's not there on the hemangioma study. So that means it's not a hemangioma. They're going to biopsy that to determine if it's cancer. All right, HIDA scans. You've probably done a lot of HIDA scans. The purpose of the HIDA scan is to see if the gallbladder is functioning. So this is what it looks like on imaging. This is what it looks anatomically. So you can identify all the different areas. And this is 60 minutes of imaging. Okay, so what we're looking for is we're looking for the liver to show up. We can see the gallbladder showing up, and then we can see the bowel showing up. So that's what we're looking for in our first 60 minutes of imaging. This one as well. Now there's 3 possible diagnoses. You can have normal, chronic cholecystitis, or acute cholecystitis. Okay, so with these images right here, we've ruled out one of those. Which one have we ruled out?
Oh, this is normal.
It might be normal, but it might also be chronic. So it's
you can see the bowel.
Right. It's not acute. It's not acute, because if you see the gallbladder, it's not acute. Okay. You'll never see acute gallbladder because gallbladders are ugly. Okay. You'll never see acute gallbladder. If you see it, it's not acute. So that's all we know. At this point, it's either normal or chronic. How do we tell if it's normal or chronic?
If we see the bowel and everything, then it's normal. Now we don't see the bowel, it's chronic.
Okay, so chronic is going to be determined if we're going to the ejection fraction. We're going to give CCK or boost, and we're going to get an ejection fraction. If the ejection fraction is normal, it's normal. If the ejection fraction is abnormal, it's chronic. All right, so I'll skip through that. Okay, this no more, this no more. This is the only one we have is mebrofenin. And we're going to give anywhere between 1.5 and 5 millicuries. If the patient has hyperbilirubinemia, so a high bilirubin level, then we need to give them extra TEC mebrofenin, because the mebrofenin is going to be competing with the bilirubin, which is high in the patient. So we have to give them extra. It's going to take longer for it to get into the gallbladder just because their bilirubin level is elevated. Okay, we want them MPO for at least 2 hours, but preferably 4. If they've been fasting for too long, it could make a false positive, because the gallbladder is going to be full of bile. And when you inject the mebrofenin, there's no more room. It's like there's no room for the extra mebrofenin, so it won't go into the gallbladder. So it looks like it's going to be acute, because if the gallbladder doesn't show up, it's acute. So normal is when the gallbladder shows up on time and a normal ejection fraction. Chronic is the gallbladder is either late or low ejection fraction. And acute is when the gallbladder doesn't show up at all. The other 2 things we can do is if the patient has a biliary leak. This is after you have surgery. Sometimes when there's an incomplete closure of the duct, and so the bile can leak into the abdomen. Very painful. This is an easy study to do. We just inject the mebrofenin, and we're looking to see if it's pooling in the patient's side. And then biliary atresia. This is for babies that are born where their biliary tree is not open. And so this is super easy as well. You inject the mebrofenin, You take images and you're just looking to see if the activity makes its way into the bowel. If it makes its way into the bowel, it's fine. All right, so 60 minutes of imaging. All we know is that the gallbladder is not acute. It could be chronic. It could be normal. We have to stimulate it. We're going to stimulate with CCK, also known as Syncolide. And what CCK is, it's a hormone that your body produces anyways. So when you go to lunch today and you get that cheeseburger, your body's going to produce cholecystokinin. It's going to cause the gallbladder to squeeze, squeezes bile into your duodenum, and that's what's going to digest the fat in your meal. All right. But we're going to give synthetic CCK, Syncolide. And the dose we're going to give is 0.02 micrograms per kilogram. And we're going to give it over 30 to 60 minutes. We used to give it over 3 minutes. We don't do that anymore. I shouldn't say that because sometimes I talk to a client and I'm like, we don't do that anymore. And then they're like, well, we do that. I'm like, okay, well, that's fine. But usually we're doing it over 30 minutes now. How long do you guys inject over?
They have a drip, put it on the pump, and then they stand dynamic while they infusing that.
Okay. All right. So take images anywhere from 30 to 60 minutes afterwards. Now, if a patient has been fasting for a long time and their gallbladder is full of bile and the mebrofenin can't get in there, we can actually pre-treat. We can give them a little bit of CCK, cause the gallbladder to squeeze a little bit, wait an hour or two, and then go ahead and do the study. All right, so this is what it looks like. You get a time activity curve, gallbladder emptying, region of interest is drawn around the gallbladder. We can also give a fatty meal instead of CCK. So if we give Boost, Boost has 7 grams of fat in it, and that's the same amount of fat that would cause your body to produce that equivalent CCK. All right, what is the equation for ejection fraction?
The net gallbladder max minus the net minimum, and then over the max times 100.
Yes, yes. So full minus empty divided by full, or big number minus little number divided by big number. All right, when we draw our region of interest, we draw it here. Our background, we draw up here. How come we draw the background up in the dome of the liver?
Because we still have a little bit of uptake in the liver.
Yeah, and the gallbladder actually sits anterior to the liver. So some of the liver counts are shining through that gallbladder and we're picking up that activity. So we have to subtract out what's in the liver. All right, so we already talked gallbladder ejection fraction. We would take the big number minus the little number divided by the big number. Times it by 100. And in this case, it comes out to 62%. So just make sure you put that in your calculator later and you get the right answer. All right, now at this point, we're at 60 minutes. What do you see?
See the bowel.
You see the bowel. What else do you see?
But still don't see the gallbladder.
Right, you don't see the gallbladder. So at this point, we know it is not normal. At this point, it's either going to be chronic or acute. The only way we can tell if it's chronic or acute is either do a delay image or give them morphine. Do you do delay imaging there or do you do morphine?
We do morphine as well, but with that doesn't show up, then we have to wait 4 hours.
Oh, okay. So you'll do both. That makes sense. So delay imaging 3 to 4 hours later, and you're basically just waiting for that activity to finally make its way into the gallbladder. If it does, it's chronic. If it doesn't, it's acute. Now, the other thing you have to keep in mind is if there's no activity left in the liver, then there's no way it's going to get into the gallbladder. So in this case, you can still see activity in the liver, so that's fine. But sometimes you don't see the liver at all. You either have to give a booster dose or it's just not going to work. Morphine, if you give morphine, this is the dose here, 0.04 to 0.1 milligrams per kilogram. We're going to give it slowly and then continue image for another 30 minutes. And then, like you said, if it still doesn't show up, then you can do a delay. All right, so how does the morphine work? It actually works on the sphincter of Oddi. So right here in between the common bile duct and the duodenum, there's a sphincter there. And the sphincter of Oddi will constrict when you give morphine. And so that'll cause a backflow as the Mebrofenin's coming down, it'll cause it to backflow into the gallbladder. All right, this is a biliary leak study. So we know the patient doesn't have a gallbladder. And so what we're looking for is this activity right here. It's going to pool in the right side because as it's coming down the biliary tree, it's leaking into the gut. So instead of seeing like nice intestines, we're going to see a leak. We also see it up here. All right, so here's another biliary leak. All right, so here's 30 minutes of imaging. What do you see?
I don't see. Oh, yeah.
Okay.
But there's uptake on the duodenum.
Yep. All right, so we're seeing liver, we're seeing gallbladder, and we're seeing bowel. Liver, gallbladder, and bowel. So at this point, the only thing we know is it's not acute. It's either chronic or normal. So we're going to squeeze the gallbladder. Here's the gallbladder. We're going to squeeze it, and it looks like just about all of it squeezed out. And so we'll do an ejection fraction. Ejection fraction here is 92%. So is this patient normal?
Yes.
Yes.
Over 38%.
Perfect. Yes. All right. How about this patient? Here is 60 minutes of imaging.
Mm-hmm. So no gallbladder, no bowel, no common bowel duct.
Mm-hmm. Yeah. Even at 5 hours. At 5 hours, we can turn up the intensity and we can see a little bit of bowel. So we are actually seeing bowel. So this actually indicates either the patient's having liver failure because they're not making bile, or it's acute cholecystitis. Because here on CT you can see the gallbladder, but it's not working at all.
Mm.
All right, this is called the rim sign. And so you can see this rim of activity where the gallbladder sits. So the gallbladder is actually right here. Okay, so this rim of activity is above the gallbladder, and that's inflammation. So the gallbladder is so sick that there's blood flow going to that area trying to fix it. So that's acute cholecystitis. That gallbladder is coming out. All right, here's 30 minutes of imaging, 60 minutes of imaging. What do you see?
I don't see the common bowel ducts, but there's bowel.
Mm-hmm. Okay, so you're seeing liver, gallbladder, bowel. So at this point, all we know is it's not acute. It could still be normal. It could still be chronic. So now we're going to squeeze the gallbladder. All right, so we have more bowel, which is great. And now our ejection fraction is 20%. So what is this?
So it's abnormal. So it's acute. Chronic.
Chronic, yes, perfect. It's chronic. All right, how about this one? Here's 60 minutes imaging and 3-hour imaging.
So no gallbladder, but we see gallbladder at 3 hours. So that is chronic.
It is chronic, yes, very good. All right, we talked about that and that. Okay, we're going to go through this. All right, gastric emptying study. Do you do these?
Yes.
Do you use liquid egg whites or whole eggs?
Liquid egg white.
Oh, very good. It's music to my ears. I love when I hear that. Yes. All right, so this is why we do a gastric emptying study. There's several reasons for slower emptying or faster emptying. We're usually doing these for slower emptying though. Now, we can do this with solid or liquid. And if the patient eats a solid meal, gastric emptying is actually sigmoidal. Liquid gastric emptying is exponential. So this is normal. So we're going to have different numbers based on if we're doing a solid meal or a liquid meal. So the solid meal should be done with egg whites. That is the best thing because it's the protein in the egg whites that binds to the sulfur colloid. When I was in school, I went and was doing clinicals, and they would crack the egg open. So they used a whole egg, and they were injecting right inside the egg yolk. And I'm like, why are you injecting in the egg yolk? I thought it would bound to the egg white. And sure enough, I was right as a student. Egg whites. Liquid can be done with water or milk. Milk is not necessarily going to give you this exponential curve, though. It could be more sigmoidal because milk is going to be digested as a solid. All right, so here's your standard meal. Make sure you know that. 120 grams or 4 ounces of liquid egg whites, white bread, strawberry jam, water, and 0.5 to 1 millicuries of sulfur colloid. When I was at my previous job, all of the hospitals in that area, they were using 1 to 2 millicuries of sulfur colloid. And that's too much because the lining of the stomach and the intestines are very sensitive to radiation. And so you want to give less radiation. All right, so there's the dose for sulfur colloid. If you do liquid and solid at the same time, you can do liquid with indium-111 DTPA. All right, NPO, 6 to 8 hours. That's why we usually do these in the morning. We just say nothing to eat after midnight. You want them to eat the meal within 10 minutes because if it takes longer, they're going to start digesting before you get that 0-minute image. Also document the total time. We're going to do anterior and posterior and then get what's called the geometric mean, which is the square root of the anterior times the posterior. There were some studies like, well, maybe we can just do an LAO, but those were not accurate. So we're back to doing anterior and posterior. We used to calculate the percent empty, and it was very easy, but we decided to make it more complex. Now we calculate the percent remaining. So the way to read this table is put that 100 in there, put these zeros in here. These are the ranges that are normal for all of these time periods. If it's higher than that, that's gastroparesis. If it's lower than that, it's going to be dumping syndrome. They're emptying too quickly. All right, so how do we do the geometric mean? Do you have your calculator?
Yes.
Awesome. So we're going to take the square root of the anterior counts times the posterior counts. So plug that in and tell me what you get.
Uh, 24283.
Perfect. Okay. So here's our example. We're going to calculate the percent remaining at 30 minutes, given the following data. I'm going to tell you what these are. This one comes out to 68,982. Geometric mean of time 0 is 77,312. All right, so these are my 30-minute counts and my 0-minute counts. To calculate the percent remaining, which one goes in the numerator and which one goes in the denominator?
Remaining. So
Motion detected at front door.
it's square root of the A times P.
Okay, so I gave you the square root of the anterior.
Oh,
Yeah. So my question is we're going to calculate the percent remaining. Which number goes in the numerator and which number goes in the denominator?
the 30 minutes go on the bottom.
30-minute goes on the top.
Oh, okay.
Yeah. So anytime you're trying to figure out the percentage of something, that always goes in the numerator. So if I want to know the percentage of counts remaining at 30 minutes going in the numerator. Okay. The denominator is going to be the 0 minutes. But I have to do one other thing before I can put this in my calculator.
Is it decay first, the 30 minutes?
Yeah, which one am I going to decay, the top number or the bottom number?
The top one.
No, it's going to be the bottom number because at time 0, there was no decay. At 30 minutes, that was 30. These counts have already decayed 30 minutes and these haven't. So I need to multiply this by the 30-minute decay factor.
Mm.
All right, plug that in your calculator and let me know what you get.
Uh, 0.94 times 100.
94.5%. Excellent. Okay, so that's 94.5% at 30 minutes. Is it normal? Between 70 and 100, so it's normal. Okay, we're going to skip through that. All right, let's take a look at a couple of these. So this is the normal upper limit, and then this is the normal lower limit. And these This thick line is the patient. Is this normal or is this abnormal?
So it's over 100. The time is 120. 100.
This is time, and this is the patient's emptying. Right here is the patient's emptying. This is the upper limit, and this is the lower limit. So it's outside of that limit, and since it's outside of that limit, it's going to be abnormal. Since it's on the left side, that means that they're emptying too quickly. So the curve needs to be between the two normals, and it's outside of it. All right, this one. So here is the upper limit of normal, the lower limit of normal, and now my curve is here. So that's abnormal,
Mhm.
and my percent remaining is too high. And so that means I have gastroparesis. All right, Meckel's diverticulum. We don't do a lot of these. What a Meckel's diverticulum is, it's basically like a fake stomach. So when the embryo is forming, before it forms its own stomach, it's going to be feeding off the yolk sac. And the yolk sac, when it closes up, sometimes it doesn't close properly, and you end up with this Meckel's diverticulum. And so it's going to be producing hydrochloric acid just like the stomach is. It'll cause bleeding, and it causes a lot of pain. Now, sometimes it can stay dormant. Okay, so you're born with it, but sometimes it can stay dormant for many, many years, and you might not diagnose it until later in life. So since it's a stomach, basically, we're going to give straight tech. And straight tech is going to go to the stomach as well as the Meckel's diverticulum. We can give cimetidine. Cimetidine is like an acid reducer, and cimetidine is going to prevent the Tec sulfur colloid from secreting outside of the gastric mucosa, so it makes it more sensitive, makes it stick in there longer. Super easy scan, no prep. You inject straight tech, 8 to 15 millicuries. You image, and you're just basically looking in the lower right quadrant for a Meckel's to show up. So this is actually normal visualization. You have the stomach and the bladder. This is a positive study where you can see it should show up at the same time as the stomach. Another positive study. This is the Meckel's. Down here, that's the bladder. That's the Meckel's. And another one. And another one. All right, GI bleed. So GI bleed, we talked a little bit about last time. We're going to use Tec labeled red blood cells, and we're just looking to see if the bleeding is outside of the great vessels. 20 to 30 millicuries. You want to check your patient's blood pressure, because if they are internal bleeding, that could cause their blood pressure to go down. A lot of different protocols. You should start with a dynamic first to see if you can, see where it's bleeding. And then, it's just kind of like a HIDA. Take a picture every minute for 60 minutes and, see what it looks like. You can take delays. You can take delays up to 24 hours later. We used to do that all the time. So this is normal biodistribution. Spleen is going to be hot because no matter how careful you are labeling those cells, you're still going to damage some of them, and damaged red blood cells go to the spleen. This is going to be liver. This is heart at the top. And what you really want to do is you don't want this much heart in your field of view. You should really cut off like right about there, because if that's in your field of view, it makes your grayscale. So you have like a 0 to 100 grayscale. This is taking up about 50% of your grayscale, which means this is all you have left in terms of contrast to see what you want to see. But once you move that out of the field of view, now all of a sudden you have the full grayscale to be able to see it better. All right, so here obviously is a bleed. I've got another bleed here in the large bowel. And another one. All right, the last one we're going to talk about is TheraSpheres. Do you guys do TheraSpheres there?
Yes.
Okay, so this is a treatment, yttrium 90, and we're treating liver cancer. So hepatocellular carcinoma. And we're going to do that by injecting these Y90 particles. So they're actually like little capsules. Goes directly into the hepatic artery, through the hepatic artery, and we take it right into where the tumor is. Now, these particles, about 25 microns, okay, so almost the same size particle as our MAA particles. So before we do this, we want to ensure that if we inject these Y90 particles, we want to ensure they're not going to leak out into circulation. Because if they leak into circulation, since they're particles, where are they going to go?
To the blood, to the whole body.
Okay, and once it goes into the right side of the heart, it goes to
To
the
the,
lungs. The lungs, yeah. And so it's going to stick in the lungs, and we don't want to put a bunch of Y90 particles into the lungs. So before we do this, we're going to inject TEC-MAA. Not us, the physician. We're going to walk in with a syringe of MAA, and they're going to inject the TEC-MAA directly to where they intend to inject the Y90 particles. And then we're going to take an image. We're going to image the lungs, and we're going to image the liver. We can do anterior and posterior. And we're evaluating what percentage of counts are going to the lungs. And so to calculate that, you're going to take lungs, because again, whatever you want to know the percentage of, that goes in the numerator, over the total. And that's going to tell me the percentage that's going to the locked up. Okay. Sorry. Less than 10% is good. 10 to 20% is maybe, okay? You might do a dose reduction. Greater than 20%, you can't have the therapy. The other thing the package insert says is 30 grays, okay? And that doesn't make a lot of sense to us because we're not radiation therapists. Radiation therapists talk about grays all the time. So gray is the absorbed dose, and the basically Y90 particles, they want to give 120 gray to the liver. So they want an absorbed dose of 120 gray. If 30 gray goes to the lungs, that's going to be too much damage to the lungs. So then they can't have it. So they'll find out the percentage. They'll see how much they're going to give the liver. And then that determines if they can have the therapy or not. So less than 30 gray or less than 10%. All right, that was GI. I'm going to stop the recording, and then I'll start a second recording.